gastrointestinal cancers. We'll now hear from Dr. Belinda Lee.
Good evening, it's Belinda speaking, and I'm talking to you about upper GI cancers. So just to give you a brief overview, I'll be talking about gastric cancers, biliary tract cancers, and pancreatic cancers. There's quite a lot to get through, so I'll try to be as brief as possible and really focus it down to what I think is important for you to understand. So starting with gastric cancer. Gastric cancer is the third leading cause of cancer death worldwide. There has been a steady decline in the incidence of gastric cancer in most countries over the last 50 years. However, it does still remain a major health problem. The incidence of distal gastric cancer has declined, but there has been a rise in the cancers affecting the gastroesophageal junction, so the GOJ junction, and the cardia of the stomach. This may reflect the changing etiologies, which we'll discuss later. 90% of cases are adenocarcinomas, of which 31% are found in the gastric cardia, 26% in the atrium, 14% in the body of the stomach, and 10% involve diffuse infiltration of the stomach wall. This is also referred to as lineasis plastica, and in the figure on the right-hand side, you'll see that this is visible on the CT scan as a thick rim outlining the stomach that's marked by the 3 arrows. Gastric cancer in general has a very poor prognosis. The median 5-year survival of resectable gastric cancer is only 36%, with a median overall survival of about 25 months. The highest rates of gastric cancer reported in East Asia, South America, and the Eastern European countries. Social economic status is inversely correlated with the incidence of gastric cancer. Factors associated with low social economic status, such as poor sanitation, poor nutrition, inadequate handling and preservation of food and water, are involved in the etiology of gastric cancer. Red meat, processed, smoked, salt, and pickled foods, generally foods prepared using high concentrations of nitrates, are associated with an increased risk. On the other hand, diets with high amounts of fresh fruit, vegetables, ascorbic acid, and beta-carotene are associated with a reduced risk. Chronic infections such as EBV and Helicobacter pylori are also believed to cause chronic inflammation, which could be linked to tumorigenesis. Ethnicity and geography also appear to play a role. There is data to suggest that people living at higher altitudes may also be at risk. There's still ongoing studies in this. Hereditary cancer syndromes may also play a part. In particular, diffuse gastric cancer is the most common genetic predisposition syndrome for gastric cancers, with germline truncation mutations in the E-cadherin gene, that's a CDH1 gene, detected in 30 to 50% of diffuse type gastric cancers. Families with these mutations tend to have an autosomal dominant pattern of inheritance with very high penetrance. Other inherited conditions include Lynch syndrome, familial adenopolyposis, and Peutz-Jeghers, also associated with increased risk of having gastric cancer. There are also other factors such as pernicious anemia with type A autoimmune atrophic gastritis, as well as exposure to radiation, which can increase your risk of gastric cancer. Most patients who present with gastric cancer are often asymptomatic in the early stages, and so they present at very advanced stages. The most common presenting symptoms include weight loss and abdominal pain, epigastric fullness, nausea, loss of appetite, dyspepsia, and mild gastric discomfort may also occur. Dysphagia may be a prominent symptom if patients have tumors in the cardia or in the GOJ junction. In patients with antral and pyloric tumors, they often present with vomiting and gastric outlet obstruction. Initial staging investigations should include endoscopy. So endoscopic ultrasound, known as EUS, should also be performed. EUS has a sensitivity of 85% in assessing depth of tumor invasion and detecting nodal involvement prior to surgery. Laparoscopic staging prior to surgical resection is also advocated, as this has an impact on the preoperative treatment decisions. CT scans, including thorax abdo-pelvis CT scanning, should be performed in order to test the primary tumor, the lymph nodes, and the distant metastasis. PET scans may be requested prior to surgery if patients are potentially resectable, and this will exclude other sites of disease which are not captured in the CT scan of the thorax abdo-pelvis. With regards to precancerous conditions, as per the European Society of GI Endoscopy guidelines, patients with extensive atrophy and intestinal metaplasia should be offered endoscopic surveillance every 3 years. At least 4 biopsies from different areas, including the proximal, distal, and the lesser and greater curves of the stomach, should be taken in order to make an adequate assessment of the potential for malignant gastric conditions. If H. pylori infection is present, eradication should be offered to prevent high-grade dysplasia or carcinoma developing. The use of COX-2 inhibitors and antioxidant supplements are not endorsed as approaches to decrease this risk of precancerous lesions. Patients with dysplasia or cancer within an endoscopically visible lesion should undergo staging and resection if a lesion is found. Triple therapy, this includes the use of a proton pump inhibitor and 2 antibiotics, which could be clarithromycin and amoxicillin or metronidazole, should be offered to patients for at least 10 to 14 days as a first-line treatment for H. pylori infection. Eradication rates with this triple therapy, particularly with PPI, clarithromycin, and amoxicillin, have been noticed to be decreasing worldwide. Overall, 14 days of therapy is recommended over a 7-day regimen. Here we see the gastric staging table. So this is a TNM table. However, both TNM and AJCC systems are used for staging gastric cancer. The T in the TNM stands for the size of the tumor, as you can see on the right-hand picture. N is for the nodal status, and in particular there are different stations, so N1, N2, and 3 stations for gastric cancer. And M stands for metastasis. Metastasis that may invade directly into adjacent organs, such as the colon, liver, and pancreas, or spleen, or they can go to distant sites, such as the lung or elsewhere. If metastasis is spread to the umbilicus region, this is known as a Sister Mary nodule. Sister Mary Joseph nodule. If it spreads to umbilicus, if it spreads to the left supraclavicular fossa, this is known as a Burkitt's node. And if it spreads to the ovaries, then this is a Krukenberg's tumor. When we look at the management of gastric cancer as a pathway, the first thing to say is that all gastric cancers should go through an MDM. T1A gastric cancers are amenable to endoscopic resection if they are well differentiated, less than 2 centimeters in size, then there's no evidence of ulceration and they're confined to the mucosa. Complete surgical resection of T1 gastric cancers often offers potential for long-term survival, so these patients do very well. If this is completely resected, then no further treatment is necessary if there's no residual disease. For larger lesions, the preferable management is still operable gastric cancers. So these are stage 1B to 3C. So anything from a T1N0 and beyond should be considered for surgery. And these patients should be offered pre- and post-operative chemotherapy treatment. Alternative management with chemoradiotherapy followed by surgery may also be acceptable. If patients are medically fit enough, then a D2 lymph node dissection should be considered standard treatment. For metastatic gastric cancer, then palliative chemotherapy or discussion about best supportive care should be offered. The type of surgery performed for gastric cancer depends on the extent and location of the tumor. Therefore, preoperative evaluation is very critical. Complete resection is the only curative treatment. 2/3 of patients will have unresectable disease at presentation. There are 2 principal types of gastric resection. There's the subtotal gastrectomy and the total gastrectomy. And this is shown in the pictures on the bottom on the left-hand side. Total gastrectomy may not be necessary as long as the free resection margins can be obtained by a subtotal gastrectomy. Figures 23 and 24 on the right-hand side demonstrate that the distal tumors can be managed with a subtotal gastrectomy, whilst proximal tumors usually require total gastrectomy. D2 resections are more common in Asia, particularly in Japan, because patients tend to be younger and fitter, therefore will be able to tolerate a D2 resection. However, in Western centers, more limited D1 resections are often performed, so this refers to the nodal status that was in the earlier slides. A modified D2 resection should be considered for patients who are suitable for this. Neoadjuvant chemotherapy is offered preoperatively to potentially resectable patients to help downstage them. So these are patients with T3 and N1 gastric lesions, as well as lesions of the esophageal gastric junction. ECF was previously the standard of care for patients following the MAGIC trial. This reported median overall survival of 25 months and 36% 5-year overall survivals from that trial. More recently, just at the ASCO 2017 conference, results from the FLOT4 study were presented. And this compared a combination treatment for FLOT4 against the standard which was used in the MAGIC, so the ECF-ECX combination. This shows a schema for the FLOT4 study design. This was a multi-center, open-label, randomized phase 2-3 study comparing docetaxel-based triple therapy against the epirubicin-based triple therapy of ECX or ECF, which is the current standard of care. The study recruited 716 patients over 4.5 years with a total follow-up of 6.5 years. This study has reported significant improvements in survival outcomes with progression-free survivals of 30 months versus 18 months, as well as 5-year projected progression-free survivals of 41% versus 31% favoring FLOT. Looking at the overall survival, the FLOT study showed that patients receiving the FLOT combination had a median overall survival of 50 months compared to 35 months. And this shows a 9% improvement in 5-year overall survival overall. Overall, the FLOT study also showed greater rates of curative resection as well as greater rates of pathological CR. So they showed a pathological CR of 16% compared to 6% with ECX. But both treatments have similar safety profiles, so therefore FLOT is now considered the new standard of care in preoperative treatment of gastric cancer. With regards to adjuvant therapy, so some of the data for adjuvant therapy is slightly inconsistent, but overall adjuvant radiotherapy has been associated with better overall survival and recurrence-free survival. There was a series carried out by the Mayo Clinic, and this showed overall survivals improved with radiotherapy compared to observation alone, with overall survivals of 23% versus 4%. When you look at adjuvant chemotherapy versus surgery alone, this hasn't shown consistent results. This could be partly related to geographical differences in surgical practice as well as the patient populations. The current EVQ Australian guidelines recommend that adjuvant Xelox, so that's capecitabine with oxaliplatin for stage 2 or 3 gastric adenocarcinomas post-D2 gastrectomy can be used, and this is based on the results from the CLASSIC trial, which was carried out in Korea. I think the caveat to this is that there is limited evidence for this combination in non-Asian population, as that particular study was carried out in Asia. The table here shows the results from the different adjuvant studies performed in the United States, Europe, and Asia. And what you can see is that the top 2 lines represent the results from the Western countries, and the bottom 2 lines represent the results from the countries in Asia. I mean, of note, the surgical extent is different for the two. So in the Asian countries, the majority of patients are having T2 resections, whereas in the Western countries, they're often having a modified D2 or a D1 resection. So this could reflect the outcomes that you're seeing on the far right with the overall survivals. In terms of patients with advanced or inoperable metastatic gastric cancer, they should be offered palliative chemotherapy. This improves median progression-free survival and overall survival from 3 to 13 months. It has also been shown to improve quality of life and to be cost-effective. However, I do appreciate that decisions regarding chemotherapy should be made on an individual basis. The NCC guidelines recommend palliative chemotherapy or entry into clinical trial in advanced inoperable gastric cancer. Platinum-based chemotherapies and combinations such as epirubicin, cisplatin, and 5-FU, or docetaxel-based chemotherapies can be offered as first-line regimen treatments. With regards to second-line treatments, in America, so what's reported here is actually from American studies, show that there is the option of using an angiogenesis inhibitor, such as Avastin, in this setting. Just to also note that the use of an angiogenesis inhibitor is actually not currently refundable by the Medicare system in Australia. So more recently, we've had results looking at a particular subgroup of gastric cancer. So these are HER2-positive gastric cancers. And what we know is that overexpression of the human epidermal growth factor receptor 2, so HER2, is a significant negative prognostic factor for gastric cancer. In these patients with HER2-positive disease, trastuzumab plus cisplatin 5-FU can be offered. So this has been extrapolated from or taken from the results of the TOGA trial. So that was trastuzumab with chemotherapy in HER2-positive advanced gastric cancer patients. And this showed that 22% of the patients with advanced gastric cancer were found to overexpress HER2. So this study looked at 594 patients with HER2-positive gastric cancer, and they're randomized to receive standard chemotherapy alone or chemotherapy plus trastuzumab. So the other name for trastuzumab is Herceptin. Overall survival with the trastuzumab patients was 13.8 months compared to 11.1 months in the chemotherapy alone group. So this was statistically significant with a p-value of 0.0046. Although this benefit is modest, it does represent 2.6 months improvement in overall survival, and this is clinically meaningful to this group of patients who have very poor prognosis. So work by groups such as the TCGA have classified gastric cancers based on molecular classification. And there's increasing research in gastric cancer, which is looking at categorizing patients according to things like the EBV status, MSI, which is dependent on your mismatch repair deficiency status, CNI, and GS status. And this will help us to pick out patients who are better responders or potentially resistant to treatment. Looking to the future, we're really coming into an era of immunotherapies, where immunotherapies are being used increasingly for more and more cancers. And gastric cancer is no different. So what we found is that in gastric cancers which have an MMR deficiency, they do respond better to immunotherapies. So MMR deficiency is present in 5 to 22% of gastric cancers, and this has implications on immunotherapy response rates, which are shown to be between 40 to 50% for patients within this MSI high group. Just last month, the FDA have approved the use of pembrolizumab for the use in MSI cancers that have progressed on standard therapy. So this is agnostic of the primary tumor site. This table shows response to PD-1 inhibitors such as pembrolizumab and nivolumab based on the PD-L1 staining. So this is not based on the MSI high status that we were previously talking about, but PD-L1 staining. I'm now going to move on to the next tumor type, which is cholangiocarcinomas or biliary tract cancers. So these are malignancies of the biliary duct system, and 95% of these are adenocarcinomas. They mainly originate in the liver and the extrahepatic bile ducts, which terminates in the ampulla vata. You can see that on the diagram on the right-hand side. You can also see on the diagram on the right-hand side that there are 3 anatomical regions. So cholangiocarcinomas are classified into intrahepatic, extrahepatic, or perihilar, and then distal extrahepatic. And you can also see the distribution and incidence of these type of cancers, with 10% in the intrahepatic, 60% being in the perihilar region, and the remaining 30% are distal. In the middle of the slide, you see the figure which shows the bismuth classification for perihilar tumors, and this has implications for surgery that we'll discuss later. With regards to the epidemiology of cholangiocarcinomas, there's approximately 2,500 cases reported per year in the United States. Gallbladder cancers represent about 5,000 cases per year in the United States. The highest annual incidence in Japan and Israel is between 5.5 to 7.3 cases in every 100,000 people, respectively. Early stage resectable disease has a 5-year overall survival of approximately 20 to 40% with surgery. Intrahepatic cholangiocarcinomas are reported to have a median overall survival of 30 months, with perihilar cholangios a median overall survival of 36 months, and gallbladder cancers between 8 to 79 months. Patients with advanced disease are reported to only have median overall survivals of 6 months. So like the other upper GI cancers, cholangiocarcinomas do represent a very poor prognostic group. In terms of risk factors associated with cholangiocarcinomas, I think a strong risk factor associated with this are exposure to particular chemicals. So often patients who have worked in dye factories or in printing factories may often be exposed to some of these chemicals, such as vinyl chloride, methane chloride, 1,2-DCP. The heavy infestation of liver flukes is also associated with cholangiocarcinomas, and this is endemic in Asian countries and the far east of Russia. A family history of autoimmune disease with primary sclerosing cholangitis represents a 10% lifetime risk of cholangiocarcinoma. Patients also with a history of ulcerative colitis do have an associated risk of cholangiocarcinoma. So similarly to other upper GI cancers, cholangiocarcinomas tend to grow very slowly and they infiltrate the walls of the ducts and then dissect along the tissue planes. Because of this, they often present very late with unresectable metastatic disease. The common symptoms that they present with include obstructive jaundice, so this might represent as dark urine, pale stools, skin and sclera discoloration, so yellow discoloration. Patients often report weight loss of more than 50%, as well as loss of appetite and fatigue. Hepatomegaly and pain in the upper quadrant can occur, but this happens to occur with cholangiocarcinomas in the hilar region, as well as gallbladder cancers. Sometimes patients present with a life-threatening infection of cholangitis, and this requires immediate antibiotic intervention as well as aggressive biliary drainage. If the cholangiocarcinoma is located distal to the cystic duct, then you may find that the patients have a palpable gallbladder, and this is commonly known as a Courvoisier's sign. An abdominal mass or palpable lymphadenopathy is actually less common, but hepatomegaly may occur in up to 25% of patients. So with regards to investigations and imaging, abdominal ultrasound tends to be the first line of investigation for suspected biliary obstruction. An ERCP, which is an endoscopic retrograde cholangiopancreaticogram, and a PTC, which is a percutaneous transhepatic cholangiograph, can be used to image the intra- and extrahepatic ducts and to localize the site of obstruction. PTCs are more useful for proximal tumors, or also known as perihilar cholangiocarcinomas, and the ERCP is more useful for distal bile duct tumors. ERCP allows cytological brushings, biopsies, and endobiliary stenting. And this could be then followed on by an EUS, which is used for bile duct visualization, as well as nodal assessment and FNA biopsy. Sometimes MRCPs, that's a magnetic resonant cholangiopancreatogram, can be performed. This is a non-invasive method for evaluating the biliary tree, and also is useful because of the MRI component, which is able to show you whether there's local spread into the liver. CT scans can also be done to stage for local regional progression as well as distant spread. So here we see the pathway that should be followed for any patient who has suspected cholangiocarcinomas. So patients with deranged liver function test and elevated CA19-9 should be investigated by an ERCP. If they are found to have a positive biopsy or brushing on ERCP, they should then be managed as a cholangiocarcinoma. More often than not, the results from brushings and cytology can be indeterminate, and in that case, following the ERCP, then an MRI or an MRCP should be arranged to see if these lesions can be localized and visualized. If there is significant concern and none of the earlier investigations are showing up any results, then a PET scan can be considered. So here we see the TNM and AJC staging for cholangiocarcinomas. As previously mentioned, cholangiocarcinoma is associated with a poor prognosis. 5-year survival rates remain between 5 to 10% for patients with node-positive disease, so that's stage 2B to stage 3. And the major prognostic indicators for outcomes include margin status, vascular invasion, and lymph node involvement following surgery. Surgery provides the only possible cure for cholangiocarcinomas. The traditional guidelines for resectability of a cholangiocarcinoma include the absence of a retropancreatic and paraceliac nodal metastasis, as well as the absence of distant metastases, and such as liver metastasis. There should also be no invasion in the main portal vein or the main hepatic artery, although some centers will support an en bloc resection with vascular reconstruction. However, there should be no evidence of extrahepatic adjacent organ invasion, and there should be no evidence of disseminated disease to distant sites, such as the lung. Distant cholangiocarcinomas have a high resectability rate. Even in potentially curative resection, however, tumor-free margins can only be obtained in 20 to 40% of proximal and 50% of distal tumors. So perioperative portal vein embolization can be considered. Because histologically negative resection margins are very important for outcome, PVB may be offered, and this helps to increase the limits of the safe hepatic resection. The intent of PVD is to induce lobar hypertrophy, and this may then permit a negative margin resection in a patient who would otherwise be considered unresectable because of concerns about an insufficient postoperative residual liver volume. So the table here shows the previous NCC recommendations with regards to adjuvant therapy. So up until recently, adjuvant chemotherapy has not been recommended for cholangiocarcinomas that have received an R0 resection and have no nodal involvement. In R1 resection status or node-positive disease, chemotherapy or chemoradiotherapy can be offered. However, discussions with the patients should be had as to the benefit of this treatment. Multiple studies in the adjuvant setting have shown a trend towards small benefits with adjuvant therapy. However, none of these are statistically significant, and that's why the NCC guidelines do not recommend adjuvant therapy. However, more recently, just this year, the BILCAP study was reported. This is the largest adjuvant phase 3 trial in biliary tract cancers. And this is the first study to demonstrate a significant improvement of 15 months with adjuvant chemotherapy over observation alone following surgery. So following the BILCAP study, I think this therapy is now likely to be adopted as a new standard of care for adjuvant therapy of cholangiocarcinomas. So this table shows the results from the BILCAP study versus the PRODIGY study. And it shows that the patients receiving capecitabine had a median overall survival of 51.1 months versus patients having observation alone after surgery of only 36.4 months. So this was considered to be statistically significant with a p-value of 0.097. With regards to palliative chemotherapy in cholangiocarcinomas, there's been evidence to show that treatment with 5-FU has improved overall survival compared to best supportive care, with a median of 6 months in those receiving palliative chemotherapy versus 2.5 months with best supportive care alone. The ABC-02 study compared gemcitabine and cisplatin against gemcitabine alone, and this has shown that GemCis is superior to gemcitabine alone. And this had a median overall survival of 11.7 months versus 8.1 months, favoring the combination therapy of gemcitabine and cisplatin. Other gemcitabine-based combinations can also be offered to patients with palliative advanced cholangiocarcinomas. In patients with a poor performance status, and other options include the use of single-agent therapies such as gemcitabine alone or capecitabine, which is also known as 5-FU. Now going to move on to the third tumor type that we're discussing today, and that is pancreas cancers. So as you know, the pancreas is a gland within the digestive system. It's located in the upper part of the abdomen, just behind the stomach in front of the spine. It's made up of 3 parts, the head, the body, and the tail, and it has 2 main roles. It helps to digest food by releasing pancreatic enzymes, as well as to regulate sugar levels in the blood by producing insulin. Unlike other cancers which have shown improvements in outcomes, the projected pancreatic cancer death rate is rising. It is predicted by the year 2020 that pancreatic cancer will become the 2nd leading cause of cancer-related death worldwide. It is estimated that this death toll is approximately 227,000 cases per year. In 2013, 2,865 new cases of pancreatic cancer were diagnosed in Australia. There are several different types of pancreatic cancer, but the most common type of pancreatic cancer is ductal adenocarcinoma, and this occurs in 95% of pancreatic cancers. Ampulla cancers occur at the junction, so the ampulla ovata, where the bile and pancreatic ducts merge and join the bowel. Other forms of pancreatic cancer include cystic tumors, neuroendocrine tumors, acinar cell carcinomas. We're not discussing those today. We're only really focusing on the ductal adenocarcinomas. The ampullary and cystic tumors have similar treatments to the adenocarcinomas, but tests and treatments for neuroendocrine treatment and endocrine tumors are very different, as well as lymphomas of the pancreas may also be very different. With regards to the symptoms and presentation of pancreatic cancer, again, this is similar to the upper GI cancers, and particularly the cholangiocarcinomas. So patients often present with pain or discomfort in the upper abdomen. They may have jaundice. So in the image on the right-hand side, you see a hand which is clearly jaundiced compared to a normal hand. Sometimes these changes are subtle, and you can only really notice them when you compare them to normal. Patients may complain of pale stools and dark urine, as well as weight loss, change in bowel habit. So stools can often become looser and more difficult to flush. In addition, there may be other symptoms such as a new onset of diabetes, indigestion, and a feeling of bloatedness. Risk factors of pancreatic cancer. These include age. So pancreatic cancer mainly affects patients of the middle to older age group. Patients are usually over 65 years of age. There is an association with smoking in about 30% of patients with pancreatic cancer. They also has been associated with body weight and lack of physical activity, as well as a history of chronic pancreatitis and diabetes. About 5 to 10% of patients with pancreatic cancer have a family history. So the image on the left-hand side shows a CT scan with a mass in the pancreatic head. This is circled. And the image in the middle shows an MRI pancreatogram with a dilated pancreatic duct proximal to the obstructing pancreatic head mass, whilst the image on the far right shows a dilation of the pancreatic duct in the body and a distal stricture that's present. So investigations for diagnosing pancreatic cancer include the use of CT, MRI, and PET. Again, initial investigation should really start off with a CT scan and then an MRI if you're more concerned, and PET is only really performed if patients are potentially operable. MRCP and ERC are often very helpful, and patients often undergo endoscopic ultrasounds for sampling pre-surgery to make the initial diagnosis. With regard to staging, because many patients present very late with pancreatic cancer, it's actually very hard to give them the typical TNM staging. Because of this, they're often grouped into categories such as early stage resectable pancreatic cancer, locally advanced disease, or advanced and metastatic disease. So patients with stage 1 and 2 early stage resectable pancreatic cancer, usually this occurs in about 20% of them. 35 to 40% of patients present with locally advanced, and 45 to 55% of patients have advanced disease at presentation. There's emerging consensus on the criteria for resection. However, in general, the general rules are that the disease must not involve the arteries. So this is the celiac, common hepatic, or superior mesenteric arteries. There should be no involvement or less than 180 degrees interface with the portal or superior mesenteric vein. And there should be no evidence of metastatic disease and no nodes outside of the surgical basin in order for the patient to be considered a resectable pancreatic cancer. Patients who have evidence of early stage pancreatic cancer should be offered surgery. All of the part of the pancreas may be removed depending on where the cancer is and how much of the pancreas is involved. So in modified Whipple's involves removing the head of the pancreas, most of the duodenum, the common bile duct, the gallbladder, and the surrounding lymph nodes. A Whipple's procedure, also known as a pancreaduodectomy, is similar, but the lower part of the stomach is also removed. In a distal pancreatectomy, this involves removal of the lower end of the pancreas, whilst a total pancreatectomy removes the whole pancreas organ. The table here shows results from different trials looking at adjuvant chemotherapy in pancreatic cancers. These are really just highlighting some of the seminal adjuvant trials. There are many more, but these are the key ones. The most recent trial is the SPAC4 study, and that was reported just earlier this year, and it showed improved overall survival with a combination of gemcitabine and capecitabine. There are a number of other studies ongoing, including the APAC study, which looks at gemcitabine and Abraxane, as well as the Prodigy and UniCancer trial looking at modified FOLFIRINOX versus gemcitabine alone in the adjuvant setting. These studies have not yet reported. So just a little bit more about the SPAC4 study. So this study looked at gemcitabine and capecitabine compared to gemcitabine alone, which is was the current standard therapy for pancreatic cancer following surgery. So the SPAC study looked at 730 patients recruited between 2008 and 2014 and showed that there was a median overall survival improvement of 28 months versus 25.5 months. So this is all favouring gemcitabine with capecitabine. And so this is now emerging as the standard of care for adjuvant therapy in pancreatic cancer. Increasingly and commonly in the United States, there are many trials looking at neoadjuvant chemotherapy in the hope of downstaging disease or modifying disease to make it more resectable and to improve outcomes. However, most of this work is being done still in the clinical trial setting, and as such, neoadjuvant chemotherapy is not a current standard of care. With regards to sort of palliative and advanced disease, we know that pancreatic cancer has a very poor prognosis with limited treatment options. Chemotherapy remains a mainstay of treatment for advanced metastatic pancreatic cancer, with some proven efficacy for overall survival benefit. After years of limited therapeutic progress in advanced pancreatic cancer, the last 3 years have seen some publications with very strong positive phase 3 trials. The first of this was the pivotal study from the Prodigy 4 or the Accord 11 trial that demonstrated superior efficacy for FOLFIRINOX over single-agent gemcitabine. This trial was carried out in 342 patients as first-line palliative therapy. Then following on from that, the MPAC study demonstrated significant improvement outcomes of combination gemcitabine and Abraxane over single-agent gemcitabine. So both FOLFIRINOX and gemcitabine and Abraxane combination can be considered for first-line treatment in advanced metastatic pancreatic cancer. More recently, the Napoli-1 study has reported superior outcomes in the second-line setting with gemcitabine pre-treated patients. So this is using liposomal irinotecan in combination with fluorouracil and leucovorin. And this is compared to fluorouracil, also known as 5-FU leucovorin alone. Although these newer combinations provide small incremental gains, the median survival in patients with advanced metastatic pancreatic cancer is still limited to 12 months. There remain a lack of effective treatment options, and there is an urgent need for understanding this devastating condition better, and as such, a lot of research is now being done into pancreatic cancer in the hope of finding new novel therapies. So I've taken you through 3 different types of cancers today, looking initially at gastric cancer, then at cholangiocarcinomas, and finally at pancreatic cancers. I hope that this has been helpful, and I hope I haven't bored you too much with some of the chemotherapy side of things. Happy to take any questions.
Okay, and thanks to Dr. Belinda Lee. Thank you.